Hello and Assalamu alaikum. Until now, we have only 74 participants. Rest are still not around. But since the time has begun, so we will resume our lecture. So, we were talking about kidney, right? And there is a whole world of pathology hidden in the kidney, so much so that people have to specialize in one kidney or nephrology subject of nephrology, right? That relates to the kidney. So I'm sure if people spend their lives doing kidney for a very long time, it has a lot to tell you. It has a lot of things to discuss. Yesterday, we talked about rapidly progressive glomerulonephritis. In my mind, I thought that this rapidly progressive glomerulonephritis needs some further discussion or it needs some further clarification. And I hope you follow me, because if there is anything in your mind that is not clear, I must know and I must try to help you clarify all and any doubt that is there in your mind. So, kidney, which is chapter number 20 of your book, now you know which chapter we are reading. It is the kidney, and until now we've done glomerulus, nephritic, nephrotic syndromes, and the third syndrome was rapidly progressive glomerulonephritis. We have done one of the diseases, that is post-streptococcal glomerulonephritis. Post-streptoglomerulonephritis is a nephritic syndrome. I told you that sometimes nephrotic syndrome does convert into nephritic, and some of the diseases they just hop onto nephritic syndrome, cause inflammation of the glomerulus, glomerulonephritis, they cause inflammation of the glomerulus, and they cause nephritic syndrome, right? They cause nephritic syndrome. So if you have any query or if you're much worried, please let me know, so I will try to clarify the doubts available, so my students will not scratch their head. So I would like to revise this rapidly progressive glomerulonephritis. We said that nephritic syndromes usually may progress to nephritic syndromes may progress to rapidly progressive glomerulonephritis. And in this entity, which is a syndrome, not a disease, and it is associated with, of course, several glomerular injuries, it is associated with some diseases, or some diseases that are in particular associated with rapidly progressive crescenteric glomerulonephritis are discussed in this syndrome, right? So, uh, what are the characteristic features? Nephritic syndrome is one of the characteristic features. No urine, severe oliguria or anuria. Oliguria means urine less than 400 ml per day, or less than, some books say less than 500, but mostly it is less than 400 ml of urine per day. And once there is this entity or this syndrome, it happens, rapidly progressive glomerulonephritis, the patient rapidly loses the kidney function. If not treated, our person or patient sleeps forever. So we said that this syndrome has a feature of nephritic syndrome. What was nephritic syndrome? Does anyone remember what were the features of nephritic syndrome? I think to raise your hand, or you can just switch on your camera so I will know who wants to answer. So I will unmute that person. Is it Kutubuddin? No? Is it Aida Safdar? Would you like to answer? No? All right. So nephritic syndrome had 7 things in its features, which you have to remember by heart. And what was those 7 features? Hypertension, clinical feature in which the clinical feature was hypertension, and then there was hematuria and cast, red cell cast in the urine. There is azotemia, oliguria, yes, hypertension, we discussed that. Proteinuria, which is mild, and then there is edema accompanying the proteinuria. But there is mild edema and mild to moderate proteinuria. Right. So the features of edema and proteinuria are less than in the nephrotic syndrome. So we said that the formation of crescents on histology is proliferation of parietal epithelial cells. And then there is a lot of infiltration of the inflammatory cells. And so what happens that in a normal looking glomerulus that develops pathology, initially there is leakage of all these plasma proteins that are a feature of a nephrotic and nephritic both. And in nephritic syndrome, when these proteins, blood cells, leak out into the urinary space, they cause irritation of the parietal cells that proliferate. So once the parietal cells start proliferating, they press upon the glomerular apparatus, and in doing so, pressing on the glomerular apparatus, they decrease the urinary space, right? That causes oliguria. And since the blood vessels are involved, it causes hypertension as well. Kidney has got juxtaglomerular apparatus, so it will throw the hormones to cause hypertension as well. So this is what happens. And once the entire kidney has got a large crescent formed in it, then it will cause, if a large crescent is formed in it, then it will cause decrease in the urine, and eventually uh, there will be a lot of proteins in this space that will further compress the glomerulus and cause necrosis, and this will disappear. The whole of the glomerulus will disappear eventually, and it will be replaced by globular proteins and fluids and fibrosis eventually, and that is the end stage renal disease or chronic renal failure. So it will progress to chronic renal failure in the end, huh? This is a histological picture of the glomerulus, of the Bowman's capsule. In this, you can see proliferation of the you can see proliferation of this parietal layer of cells that has compressed the glomerulus. You can recognize glomeruli, can't you? You can recognize the Bowman's capsule and the glomeruli. I think that is easy. This is renal tubule, another tubule, another tubule. And how will you say proximal or distal? Just look at the cells. If they are cuboidal and they have cilia, it is proximal tubule. The distal tubule is smaller and the cells are flatter. The cells are flatter, and the uh, tubules do not have, the cells do not have cilia. Right. So, mechanism of injury. So, there could be 3 mechanisms how the injury is created in this rapidly progressive glomerulonephritis. Keep in mind, either the antibodies can be formed against GBM of the glomerular membrane of the glomerulus, or antibodies are formed in the body and they are deposited in the glomerulus, or there could be a granular attack of the antibodies are spread in the glomerulus in a granular fashion. Or you may not be able to see, or you may not be able to find any antibody. If there is no antibody and still a person is suffering from nephritic syndrome and is progressing towards rapidly progressive glomerulonephritis, then you think of post-immune decreased immune complex disease, that is post-immune rapidly progressive glomerulonephritis. The 2 basic causes we studied yesterday were ANCAs, anti-nuclear cytoplasmic antibodies, are antibodies against nuclear antigens, nuclear antigens of neutrophils, anti-neutrophil cytoplasmic antibodies. So it is a kidney limited disease, type 1 rapidly progressive glomerulonephritis is a renal limited disease, and the foremost disease in this case, type 1, is good pasture syndrome, right? Then type 2 is idiopathic post-infectious glomerulonephritis, lupus nephritis, Henoch-Schönlein purpura, IgA nephropathy, and others. And then in type 3 we have either it is idiopathic, we don't know, or it is venous glomerulonephritis, but they are all ANCA associated, right? So in good pastures, we said that this good pasture syndrome, which is not very good, there is an antibody against GBM that also cross reacts with the basement membrane in the lung. So it causes pulmonary hemorrhages and it causes renal failure. So this antibody is formed against the collagen, type 4 collagen, which is the collagen of the GBM, glomerular basement membrane, and alpha 3 chain of type 4 collagen. It causes pulmonary hemorrhages and it causes all these pulmonary hemorrhages and hemorrhages in the kidney. In the kidney, you can recognize all those glomeruli and the Bowman's capsule, and you can recognize the hemorrhages there. And eventually, all what it does is cause necrosis there. Lot of hemorrhages, blood everywhere, and then necrosis happens. And this is lung, where the feature is hemoptysis later on. These are the alveoli. Alveoli are filled up with blood. So the special features which we will see by the immunofluorescence is that the glomerular basement membrane looks like a ribbon. It looks like a ribbon, linear deposits of IgG and complement. The entire glomerular basement membrane, the whole of the glomerular basement membrane is under the attack, and this shows with immunofluorescence a ribbon-like deposit. See, now this diagram just shows you the difference between linear ribbon-like deposits, and it shows you a granular deposit. Just look at so many granules that are in there, right? So every time we talk about granular deposit, it is like this, and every time we talk about linear deposits, it is like this, but the granular deposits vary in different diseases. In this case, the lumpy bumpy deposit is there in post streptococcal glomerulonephritis, and in this case there is linear deposit. So that is just a comparison for you to remember, to memorize. So the antigens that have triggered the autoimmunity of good pastures is, it could be viruses or malignancy, or it can be certain HLA subtypes, for example, HLA-DRB1, and some hydrocarbons that are present in paints and dyes. It means there are some chemicals doing the same, or it could be genetic predisposition to autoimmunity. But there is no one cause, right? So like all other autoimmune diseases, there is no one cause. So the treatment is intensive plasmapheresis. So why do we diagnose what kind of RPGN is there? Is because we want to treat the patient, and the treatments are different in different sorts of, or in different classes of RPGN. In type 1 class, we can do plasmapheresis, and we could give steroids and chemotherapies to suppress the immunity. Immune complex deposits. Now, immune complex deposits, what sort of immune complex deposits did we study? We studied lupus nephritis, IgA nephropathy, which was Buerger's disease, post-infectious glomerulonephritis, and Henoch-Schönlein purpura. Immunofluorescence show granular pattern of staining that we have seen before. This is the granular pattern of staining for immunofluorescence, and and demonstrates cellular proliferation, influx of leukocytes, glomerular tufts, and addition to crescent formation. In the crescent, there are a lot of immunological immunology has caused, or immunological attack has caused invitation to the to the whole orchestra of cells that are responsible for throwing further cytokines and aggravating the inflammation. So inflammatory cells are lymphocytes, macrophages, plasma cells, neutrophils. All of them are invited. So what is special about these conditions? They cannot be treated by plasmapheresis. They require treatment of the underlying disease. So there is a whole orchestra of the cells here: macrophages, lymphocytes. This is T lymphocyte, of course, and then there are other cells, neutrophils as well. Post-immune. We studied post-immune because there is no evidence of any immune there is no immune complex. We can't see any immune complex there. So it could be cytoplasmic or perinuclear staining. So what is this one? It is cytoplasmic. Just look at this: cytoplasm has stained, but the nucleus is spared. The nucleus is spared, cytoplasm has stained, and this is the cytoplasmic anti-neutrophil cytoplasmic antibody. And this is by the indirect immunofluorescence. We have seen this, and these antibodies are usually directed against proteases 3, and most patients have venous glomerulomatosis. So is that clear? The systemic vasculitis that presents with post-immune rapidly progressive glomerulonephritis are Wegener and microscopic polyangiitis. So these are the two pathologies. Once we have come to the diagnosis of post-immune, then some ANCA is involved, whether it is cytoplasmic ANCA or it is a perinuclear ANCA. One of the two ANCAs is involved. So then what disease is it? Is it Wegener's or microscopic polyangiitis? Because those are the only two diseases causing post-immune disease. So 90% of the patients we have ANCAs, either it is P or C ANCA, but rest of the 10% of the patients have no ANCAs as well. So if there is no antibody detected in the kidney, it doesn't mean that it is not an immunological attack, and it is an immunological attack. It is just that it is post-immune, right? It is post-immune, reduced immune. So this is what PNK looks like: perinuclear anti-neutrophilic cytoplasmic antibody. This is perinuclear anti-neutrophilic cytoplasmic antibody. Look at the lobes of the nuclei. Systemic crescents are progressively related. As systemic crescenteric glomerulonephritis, they are pathogenically related because they have circulating ANCAs and similar pathological features. And small, usually it is not usually, all post-immune are small vessel diseases. Venous glomerulonephritis is small vessel, and small vascular diseases. Microscopic polyangiitis is a small vessel disease. So all post-immune are small vascular diseases, small vasculitis, limited to glomerular or peritubular capillaries. In case of idiopathic crescenteric glomerulonephritis, clinical distinction between systemic and idiopathic crescenteric glomerulonephritis has been emphasized because actually the result is same in all cases. So you can see the condition of capillaries. Which kind of ANCA is this? Looks like C ANCA, right? So ANCAs are highly sensitive diagnostic markers because they induce the disease when they are separated and put into another organism. Have 1/5 of the patients have anti-GBM antibody mediated glomerulonephritis without lung involvement. You see that? anti-GBM antibody mediated glomerulonephritis without lung involvement, which means good pastures syndrome may have no lung involvement, but the typical feature is lung involvement, right? Typical feature is lung involvement. One-fourth of the immune complex mediated crescenteric. This is just to complicate the picture that some people may be spared. However, mostly they are not spared. One fourth have immune complex mediated complex glomerulonephritis. Remainder of the posse are of the posse immune type. So, what is the morphology of the what does the kidney look like in gross and under the microscope in case of rapidly progressive glomerulonephritis? They become larger, they are inflamed. All inflamed organs are larger. They have petechial hemorrhages on the cortical surfaces. They become large and they larger than normal, and they are a lot of petechia on the surface. Glomeruli often show focal segmental necrosis, right? So there is necrosis, we discussed that before, and there is diffuse or endothelial proliferation and mesangial proliferation. So there is proliferation of the parietal epithelial layer of Bowman's capsule. There is diffuse or focal endothelial proliferation and mesangial proliferation. Is that clear? So it depends on the underlying cause. Glomeruli often show focal segmental necrosis. So this is, just look at this picture. This is normal, and the abnormal picture shows you a lot of hemorrhages there. And in the hemorrhages, there are among the hemorrhages, there are necrotic areas. There is necrosis there, right? These black areas, there is necrosis and there are hemorrhages. This is ANCA vasculitis. No antibody was detected or antigen was detected. So focal necrosis, right? Areas of tiny areas of necrosis may be there. And there is lot of mesangial proliferation because they have been irritated. Mesangium has been irritated by some cytokines. The histological picture is dominated by distinctive crescents. This is crescent. This is a crescent. Proliferation of parietal epithelial layer. This is a crescent, right? This is a crescent. This is a crescent. You see focal segmental necrosis of the glomerulus, right? So this is the segmental necrosis of the glomerulus, and then there is proliferation of the, look at the cells, proliferation of the parietal layer of Bowman's capsule. Most typical features of posse-immune rapidly progressive glomerulonephritis is segmental glomerular necrosis adjacent to glomerular segment and uninvolved by inflammation or proliferative changes. Segmental glomerular necrosis, right? Adjacent to the glomerular segment. This is the glomerular segment. And then there is focal glomerular necrosis, right? Glomerular segment, adjacent to the glomerular segment is focal necrosis, uninvolved by inflammation or proliferative changes. There is inflammation. Inflammatory cells are there. Where is it? No inflammatory cell is there. So uninvolved by the inflammation or proliferative changes. So that is what posse immune looks like. Just a segment of necrosis in the glomerulus, right? Then there is no saying no to no inflammation and no proliferative changes. Crescents are formed because of the proliferation of parietal cells and the formation of proliferation of parietal cells are because of these inflammatory cells, migration of monocytes that turn into macrophages, and this through cytokines, and cytokines stimulates the parietal cells. But there is usually presence of the inflammatory cells. Neutrophils and lymphocytes may be present as well. So all of them are invited, but the main guest of this inflammatory process is a macrophage. monocyte and a macrophage. They are all invited actually, but the main guest or the foremost guest is this one, monocyte. Look at this. Crescentic. There is proliferation of the parietal cells. Some proliferation of the parietal layer. And look at the tuft of glomeruli. Crescents are formed by the parietal cells, migration of monocytes and uh, monocytes and macrophages and neutrophil lymphocytes. You may find them in the area. Lot of monocytes are there. This is the crescent. This is the crescent. This one is a crescent, and it is compressing on the glomeruli. This is the crescent, and it presses on the glomeruli, obliterates the urinary spaces, and it compresses the tufts. Fibrin stands are prominent between cellular layers of crescent. Fibrin stands may be there. Fibrin stands may be there like that. And escapes procoagulant factors, fibrin, cytokines into the woman's cells. All of these are irritants. All of these are irritants. The fibrin strands are irritant, cytokines are irritant, and procoagulant factors, they are all irritant. They are all irritant and cause proliferation of the tuft of the glomerulus. They all cause proliferation of the parietal layer of Bowman's capsule that cause compression on the tuft of the glomerulus. Immunofluorescence case show granular immune deposits. Granular, what type of immune complex is caused by granular immune? Which disease is this? Immune complex mediated cases show granular immune deposits. The one you have studied, post-streptococcal glomerulonephritis. Rest of them are also granular, like lupus nephritis and IgA nephropathy. They're also granular, but the IgA nephropathy has something very specific in their feature. So we will study that in a while. In the next few lectures, we will cover that. This is what is granular, right? Now, this differs from the ribbon in that the ribbon does not show any granules. I told you that granular deposits may not be same for every granular disease. Every granular disease has some difference in their granular deposition. This one is quite linear and heavily infiltrated by the immune complexes, and it has granules there. Posse immune complex, you will not find any complement or any immunoglobulin or complement there because it is posse. A little immunity is shown, and that immunity is usually in 90% of the cases by the ANCAs. Electron microscopy discloses deposits in these cases due to immune complex deposition. Actually, so my students, we don't have a lot of electron microscopes in our country, and therefore we do not have a lot of facilities to hop on these electron microscopes. Therefore, we can do immunofluorescence studies, and they are very helpful, not very helpful, they are mandatory in case of diagnosis. And electron microscopy, what does that show deposits in case of immune complex type 2. Electron microscopy also shows that eventually glomerular basement membrane ruptures in severe injuries. Do you know that? That GBM can rupture as well, and particularly when there is rapidly progressive glomerulonephritis. Please note, rapidly progressive glomerulonephritis, right? This is caused after nephritic syndrome. Electron microscopy discloses deposits. So this is, if we had an electron microscope, this is all what we will see, that in severe cases, we may find a ruptured glomerular basement membrane, and this will allow the whole cells to cross. Proteins are heavily crossing their plasma proteins like coagulation factor, complements, inflammatory mediators, and the urinary space becomes clogged by the cells and and the proteins, and therefore they trigger the reaction in proliferative reaction in the parietal layer of the Bowman's capsule. Look at the wrinkling of the basement membrane, and then there is rupture of the membrane. The membrane is absent there, right? So this is these are the areas where the basement membrane has ruptured. Most crescents undergo organization when the whenever in any area of the body there is a very long standing or there is a long standing inflammation or such a havoc has been played, like there is rupture of the glomerular basement membrane, then eventually it will undergo organization. Foci of segmental necrosis resolve as segmental scars. So fibroblast will come in through collagen, and the collagen will organize to form a scar. Normal glomerular architecture may be restored with early aggressive therapy if the scar has not been made. Before the scar comes in and still there is just rupture of the glomerular basement membrane, and there is leakage of so many leukocytes, and there is leakage of plasma proteins. Before, if at this stage we treat the patient, we can reverse the disease. But if scars are formed and organization has happened, then the patient has lost that nephron. Renal manifestation of all forms of rapidly progressive glomerulonephritis are hematuria, red blood cell cast in the urine, moderate proteinuria, hypertension, and edema. And uh, those are also all of them are also a feature of nephritic syndrome. Yes. So nephritic syndrome is a feature of rapidly progressive. In good pasture syndrome, there are patients who will undergo hemoptysis that is so severe that even only hemoptysis can eventually kill the person. This is what is cola colored urine, that is a feature of nephritic syndrome, and that is also present in rapidly progressive glomerulonephritis. So, hypertension, yes, high blood pressure, eyes have conjunctivitis. I don't know why is that eyes have conjunctivitis. Does anyone else know? Eyes have conjunctivitis, kidney disease, oliguria, proteinuria. Yes, oliguria, you know why is there oliguria now? Proteinuria, you know why there is proteinuria. Central nervous symptoms. Do you know that? Renal diseases with central nervous systems. And mononeuritis multiplex, it says that discoloration of nails. Can anyone explain, any student explain why all of this is happening? Yes, I know you know now why is there hypertension, juxtaglomerular apparatus. Yes, you're right. So juxtaglomerular apparatus is there that will cause hypertension. And then eyes show conjunctivitis. I will explain in a minute why eyes show conjunctivitis. Kidney disease, oliguria, proteinuria. There's this disruption of the GBM, oliguria, parietal cells obliterate the urinary space. So there is oliguria, central nervous system. Whenever there is kidney disease, there is decreased excretion of the harmful substances toxic to the brain, and that is what causes central nervous system. Discoloration of the nails, definitely there is discoloration of the nails because of anemias, right? There, one causes anemias, and if it is a microvascular disease is not just for kidney, it is systemic, it is everywhere in the body. So Wegener's and Microscopic polyangiitis, they affect the whole of the body. In particular, Wegener's glomerulonephritis affects the whole of the body. So, we talked about conjunctivitis, and I told you that I'll let you know in a minute. Dry, red, and sore eyes are there. Why? Because of impaired blinking and tear formation leading to dry eyes. Extra calcium phosphate can settle into the eyes, causing irritation. Cornea, conjunctiva, and sclera can be affected, controlling calcium phosphate. Actually, calcium and phosphate levels are impaired in the renal diseases. Calcium decreases in the body, phosphates increase. And since they are just salts, they can deposit in the eyes and cause problems of conjunctivitis, right? Anti-GBM antibodies, serum analysis of GBM antibodies, anti-nuclear antibodies, and ANCAs are helpful in diagnosis of specific types. You have to know what type of disease is there in rapidly progressive form of glomerulonephritis. They can respond to steroids, especially type 2 rapidly progressive, type 1 rapidly progressive glomerulonephritis, and they can respond to cytotoxic drugs. Milder form of glomerulonephritis may subside. Renal involvement is usually progressive and results in severe oliguria. Despite therapy, many patients will have will end up in chronic renal failure, and they will have to have dialysis or transplantation, particularly if you don't discover the disease, particularly if you don't discover the disease. What is chronic glomerulonephritis? Is it name of a disease? Is this a special disease? No, we are not studying special diseases, and we have not studied special diseases except one that was post streptococcal glomerulonephritis. The only disease you have studied until now was post streptococcal glomerulonephritis. Rest of them are conditions in the glomerulonephritis that we have to diagnose first, and we have to know what type of glomerulonephritis the patient is suffering, and then we have to discover the disease. Chronic glomerulonephritis is the condition when we do not discover the disease, or even if we do discover the disease and it is a long standing disease that results actually in kidney failure. Must take care of our kidneys. Pool of end stage glomerular diseases fed by several streams of specific type of glomerulonephritis. They all result in chronic glomerulonephritis, like post-streptococcal, crescenteric glomerulonephritis. See the big arrow causes chronic glomerulonephritis. Membranous, focal segmental, membranoproliferative, IgE, IG, A glomerulonephritis, and so many others, they all end up in the same bag or in the same dustbin of chronic glomerulonephritis, where they make kidney useless and we have to use the dialyzing machines. Do you think my students' dialysis is something very good to have? And until now, I keep asking you, do you think we can donate our kidneys very easily? We all should donate one of our kidneys. More than half of my class usually says, yes, we should then donate our kidneys. No, you don't do that. No, you don't give away your kidney. It is risky, because I will let you know there is something called focal segmental glomerulonephrosis that develops if the kidney nephrons are deficient in any way. Symmetrically contracted kidneys, once they are in chronic glomerulonephritis, they become small in size. Chronic glomerulonephritis kidney is contracted, but both the kidneys are contracted, not a single kidney, they are symmetrically contracted, and they have diffusely granular cortical surface. So where are the nephrons located? Where is the whole functioning unit of kidney located? The whole functioning unit of the kidney is located in the cortical surface. So the cortical surface is granular, and although it is symmetrically contracted, but the granular surface, the cortical area is more contracted. It is thinned. Increased peripelvic fat. So what takes place of the kidney is all fat. Look at this kidney, look at this kidney, and there is granular surface of the kidney. Do you appreciate there are a lot of granules on the granular surface of the kidney? It looks so wasted, contracted, and useless kidney. It looks like that. So loss of cortex. Look at the cortical surface. Loss of cortex. See, students, please open atlases and read the book. Don't read it text just like that, because you will not be able to recall when you are asked in your test, or you're asked verbally. Do see pictures of that. We can't show you. It is not even possible to show every disease in real, but we can see a lot of pictures. So when we see in real, things are easier to recognize. And that is why we have got so many pictures of it. So you can see thin contracted cortex, lot of fat is there, lot of fat is there, thin contracted cortex, and it is actually a small kidney. Look at the size, it is actually a small kidney. Glomeruli undergo obliteration. Arterial and arteriolar sclerosis may be conspicuous. Marked atrophy of associated tubules is there. Irregular interstitial fibrosis, mononuclear leukocyte infiltration of the interstitium. Glomeruli, they are obliterated, all gone, obliterated. Arterial and arteriolar sclerosis. So any artery and arteriole that you see in there has thickened, and there is decreased blood supply in that. Tubules, they have atrophied, right? So we comment on each structure of the kidney separately. Glomeruli, obliteration. Arteries and arterioles, sclerosis. And tubules, atrophy. In the interstitium, there is a lot of fibrosis, and leukocyte come into the interstitium. So what happens to the interstitium? Inflammatory cells, mononuclear leukocyte infiltration. So this is how your 5 points can be remembered. Hyalinization of the glomerulus, that has undergone obliteration because of the hyalinization. Then this is partial hyalinization, it's complete hyalinization. Inflammatory infiltrate into the interstitium is seen. If there is any arteriole, it will be sclerosed. Do we see any arteriole here? Look at the inflammatory cells. We see a lot of inflammation there. This is tubule. It has shrunken in size. The tubules have shrunken in size. So therefore, tubules have atrophied. Atrophied tubules are there. Shrunken tubules, glomerular, hyalinization of glomerulus, and then what about sclerosis of the blood vessels? Where are the blood vessels? No, there was this one. This one. Yes. Highline arteriosclerosis of the arteriole. You see that? These are dilated tubules with a hyaline cast inside. They are dilated, but they are useless. The cells have atrophied in those arterioles. Inflammatory interstitial infiltrate, and then there is a hyalinization of the glomerulus. This is another stain, Giemsa stain. What will happen if we start dialyzing the kidney? Is it all right to dialyze the kidney? Yes, it will extend years of life. It will definitely extend years of life. But the dialyzing machines, when the patient is put on the dialysis, they have on itself its own complications. A kidney that has been destroyed and is not functioning will undergo cyst formation. Eventually, it will undergo malignant changes as well, right? So it will acquire some kind of renal tumor, mostly it is clear cell carcinoma, but it will acquire some kind of tumor, and arterial intimal thickening will happen, extensive deposits of calcium oxalate in the tubules, interstitium, and so we talked about calcium deposits in the eyes as well. So they are deposited in the tubules, interstitium, which means they become hard and brittle. And what happens to the arteries? Smooth muscle-like cells come in, loose proteoglycan-rich stroma, focal calcification, residual tubular segments. Let me show you that. Yes, this is the artery, and there is highline arteriosclerosis of the efferent arterioles, and we talked about accumulation of smooth muscle-like cells is there, which means smooth muscle cell is present in arterioles in any way, but this is not a smooth muscle cell, it is smooth muscle-like cell. Loose proteoglycan-rich stroma, we have seen that, and then in this arteriole, we see areas of calcification. There are pink areas of calcification as well. Residual tubular segments are there. Right. Acquired cyst, renal adenoma, acquired cystic diseases, tiny small, there are bubbles in the kidney, small cyst, small bubble like cyst, acquired cystic disease, renal adenomas, and adenocarcinomas. So both benign and malignant tumors are there, and we have a lot of cyst in the kidney. Right. So this is what we are doing is hemodialysis. We are taking blood from the artery or vein, and then we are putting it back. Complications, uremic pericarditis, uremia. Yes, that is a symptomatic azotemia. Uremia is a symptomatic azotemia. And what symptoms person can get? Pericarditis, uremic pericarditis, uremic gastroenteritis. Uremic gastroenteritis means it is actually it is acute abdomen condition of acute abdomen in which there is absolute constipation and no bowel sounds are there. And this is not of any, this is actually a chemical pathology is there, and not any obstruction or anything else is there, or perforation or obstruction, no, nothing else. No structural change is there. It's a chemical change of increased toxic substances that kidney was unable to pass. Secondary hyperparathyroidism, nephrocalcinosis, renal osteodystrophy, left ventricular hypertrophy, hypertension. Hypertension is left ventricular hypertrophy is also a feature of hypertension. Pulmonary changes of diffuse alveolar damage are often ascribed to uremia, which is uremic pneumonitis. Pulmonary changes, what are they? Diffuse alveolar damage. Clinical course insidious and slowly progresses to renal insufficiency and to death. Non-specific complaints, proteinuria, hypertension or azotemia, GFR decreases, protein loss in the urine diminishes because actually there is decreased glomerular filtration if there is oliguria and very little urine is passing. So of course the protein loss is less than that in the nephrotic syndrome. Nephrotic syndrome, how much protein was lost? 3.5 grams per day. And then there are non-specific, so many non-specific complaints that there are body aches and pains, and there are signs and symptoms of hypocalcemia, right? Signs and symptoms of hypocalcemia are there. So this is just showing you a picture. So when the GFR is more than 90, you do nothing. All treatments have the same doses as a healthy person. If there is mild derangement of the kidney, 60 to 89, decrease the dose of the drug slightly. Or if there is a moderate kidney disease, then it is 30 to 59% of the GFR has decreased, or DFR is between 30 and 89%. You decrease the dose of your drugs, and also you keep evaluating the patient, because now the patient will be much symptomatic. 15 to 29, that is very low. Fourth, severe, replace the kidney. And kidney failure altogether, less than 15%, then go for the dialysis. Right, so this is headache, tiredness, body ache, sore throat, runny nose, and fever is there. Membranous nephropathy. What is it? A nephrotic syndrome. Membranous nephropathy is a nephrotic syndrome, most common in the adults. Right. So it is most common in the adults. It's a uh, disease of adults, a nephrotic syndrome, and chronic immune complex mediated disease. It is a chronic immune complex mediated disease, diffuse thickening of glomerular capillary wall, accumulation of electron dense immunoglobulin containing deposit along the subepithelial side of the basement membrane. You can see this on the subepithelial side of the basement membrane. There is a deposition of immune complexes. These immune complexes get embedded into the GBM. They get embedded into the GBM, and reactive membrane or GBM is formed above them. They're on the subepithelial side, so you have to remember that. This is podocyte, this is endothelium, and the gray color thing is the basement membrane. The gray color thing is the basement membrane. What do the antibodies do, or antigen antibodies do? Antibodies cross this GBM and they come to lie below the podocytes and below the pedicles of the podocytes, and they form immune complexes there. This is the same crossing, antibodies shown crossing the GBM, right? And they are coming to lie on the podocyte. The antigens are located onto the, or they're embedded into the podocyte or pedicle of the podocyte. Immune complex attack is there. C5, B, C9. Accumulation of electron dense immune containing deposit along the subepithelial side of the basement membrane is there. Membranous nephropathy is of two types, primary and secondary. We have 7 minutes, so we will do much of what we can do now. Primary or secondary, the drugs that cause secondary type of membranous nephropathy are penicillinamine, captopril, gold, and non-steroidal anti-inflammatory drugs. These are penicillinamine and gold and NSDs. They are mostly used in a long-term basis in a rheumatoid arthritis patient, or a patient with having some chronic pain. But penicillinamine and gold, they are used in rheumatoid arthritis. Underlying malignant tumors, carcinoma of the lung, colon, and melanoma, SLE, infections, hepatitis B, hepatitis C, virus, syphilis, malaria, and schistosomiasis, other autoimmune diseases such as thyroiditis. Membranous nephropathy is a form of chronic immune complex mediated disease. Secondary membranoproliferative glomerulopathy, the antigens are endogenous or exogenous. The endogenous antigens may be renal or non-renal. For example, in SLE, the deposit is endogenous. has deposition of complexes of self-nuclear proteins and autoantibodies. Hmm. So look at the same diagram. These antigens can be exogenous or endogenous, right? They can come from outside the body or they can be born from inside the body. If they are in the inside, if they are formed inside the body, they can be of renal or non-renal origin, right? Renal origin means the kidney was attacked because of its own antigens, and non-renal means systemic disease like SLE. Example of endogenous antigen is neutral endopeptidase, a membrane protein recognized by a membrane protein recognizes by placentally transferred material antibody in case of neonatal membranous nephropathy. Exogenous antigens include hepatitis B virus and Treponema pallidum. Exogenous antigens, hepatitis B and Treponema pallidum, both of them are not part of our body. They are pathogens that come from outside. Those are exogenous antigens. Idiopathic, which is primary membranous glomerulonephritis, is an autoimmune disease. In certain HLA alleles, such as HLA-DQ-A1, caused by antibodies to renal autoantigen. Mostly autoantigen is a phospholipase A2 receptor. What happens now? How does the glomerular capillary wall become leaky in membranous nephropathy? The complement C5b and C9 membrane attack complex has an important role. So membrane attack complex comes in the primary case, and activates the glomerular epithelial and mesangial cells. What will happen to them now? They will start proliferating, induce them to liberate proteases and oxidants, cause capillary wall injury, and increase protein leakage. Subclass IgG and IG4 is the principal immunoglobulin deposited in case of primary membranous nephropathy. Right. So IgG4. IgG is deposited in case of membranous nephropathy, in case of primary disease, which is idiopathic, and I and a membrane attack complex may be discovered. So the membrane attack complex means all the components of C5b to C9, they are present there. See, uh, C5b and 9. So the complement components and the antibodies, these antibodies are of IgG type. Light microscopy, what will you see in the light microscopy? Uniform diffuse thickening of glomerular capillary wall, and in electron microscopy you see deposits in the epithelial side having foot processes, and basement material is laid down between these deposits having irregular spike protruding from the glomerular basement membrane. Spikes thicken to produce dome-like protrusion and eventually close over immune deposits, burying them within a markedly thickened irregular membrane. So I told you before that spiky immune deposits are present below the subepithelial in the subepithelial area of GBM, and these areas eventually close in a dome-like protrusion. Spikes thicken to produce dome-like protrusions, right? They become dome-like, and eventually the GBM closes over the immune deposits, and they bury them in a markedly thickened irregular membrane. This membrane becomes thickened and irregular, and these dome-like antibodies become buried in there. Immunofluorescence. Granular deposits contain both immunoglobulins and various amounts of complement. With passage of time, granular sclerosis occurs, glomerular sclerosis occurs, and proximal tubules contain protein resorption droplets as well, and mononuclear cells. Interstitial inflammation is there. This is diagram of your book, or the mostly the diagram of your books are shown like that. So these are the presence of immunoglobulins Ig, G, G4, and membranotic complex. And when they attach to the antibody, they form spike-like patterns that thickens to form domes. I think we are out of time now, so we will leave here and we can complete this topic, inshallah, next time. So, thank you for being patient listeners. Bye now.